Hello, everyone. Again, I am Carolina Ahumada. I am the Youth Engagement Program Lead at YouthRise. YouthRise is an international network of young people who use drugs and/or young people affected by punitive drug policies. I started working in harm reduction as a volunteer in 2017 at the organization in Argentina called Intercambios. Then I coordinated a drug checking and harm reduction program for young people in nightlife called PATH. And currently I work as an advocacy executive assistant at Intercambios as well. YouthRise is a global network of young people who use drugs and young people affected by drug policies, and we mobilize youth to engage in full spectrum harm reduction and drug policy reform. A big part of our work focuses on research with an aim to bring our lived and living experience of drug use and knowledge of the issues faced that young people face into the center of guidelines and policy documents. It is a pleasure for me to be moderating this panel of amazing and inspiring people today. We will be presenting here the latest report YouthRise has conducted to understand the needs and challenges faced by young people who use opioids and help develop an adequate public health response. Key findings from this report were presented during a side event at the 67th session of the Commission on Narcotic Drugs in Vienna. And now we wanted to make the official presentation so that everyone can be that everyone can familiarize themselves with the report, hearing firsthand from its authors and distinguished commentators as well. The participants of this study were young people who are using opioids and harm reduction practitioners, or in some cases, both. They cover the regions of North and Latin America, Europe, Southeast Asia, and Eastern and Southern Africa. A research working group of 8 representatives from Canada, Indonesia, Kenya, Mexico, Portugal, Uganda, the United States, and Zimbabwe worked together between November and December last year, managed by my amazing colleague and friend, Rebecca Calzada. Key themes were identified, including stigma, discrimination, lack of healthcare, policy issues, and political inaction to address these main issues. The findings highlight the urgent need for policymakers, state representatives, and other stakeholders to act in order to protect the rights and lives of young people who use opioids, including supporting harm reduction strategies. As I mentioned before, we will have the participation of 2 of its authors, Atika Jurista and Teresa Castro. Atika is a young harm reduction practitioner from Canada. She's the founder of J Healthcare Initiative and a member of YouthRise's International Working Group. Her advocacy focuses on expanding care options for opioid users. Her policy brief to the Parliament of Canada has influenced the consolidation of Section 56 exemption codification. Teresa graduated in social work in 2016 and is currently working as a social worker at GAT in Mouraria in Lisbon, Portugal. Teresa is the GAT Mouraria organization is a harm reduction drop-in center and drug consumption room. As a drug user herself, she has been involved in harm reduction since she was 18, initially in nightlife settings and later with more vulnerable communities. She's a peer collaborator at Cosmicer since its foundation and a member of YouthRise's International Working Group. Teresa and Atika, the floor is yours.
Thank you so much for the presentation, Carolina. And thank you to everyone who is here watching this webinar. So the theme, the title of our article is Catalysts for Change, Youth-Driven Insights in Opioid Harm Reduction. And this article is divided in different parts. and I'm going to focus on the methodology and the political context. So first, regarding the methodology, next slide. So the initial intent of the project was to produce evidence-based resource to address specific needs of young people who use opioids and also young harm reduction practitioners, with the purpose of shaping opioid-related intervention and also contributing to the improvement and to the increase of the available responses for this community. With this goal in mind, Youth Rise started a recruitment process in order to create, as Carolina already said, a research working group of 4 to 8 members. And in this call for applicants, it was stated that people with lived experience in opioid use or in harm reduction practice would be prioritized. This criteria is obviously very aligned with Youth Rise's vision of advocating for an active and meaningful engagement of young people who use drugs in the decisions that impact their own lives, meaning that they should also be involved in the development of resources that aim to positively influence their well-being. So what does this mean? This means that all the authors of this article are people who, one way or another, are directly impacted by the negative consequences of this problematic, and to whom Youth Rise gave a voice to express their feelings, their thoughts, their opinions, ideas, and perspectives. So in the end, 8 collaborators were selected. Carolina also already talked about the countries involved, which were Canada, Indonesia, Kenya, Mexico, Portugal, Uganda, USA, and Zimbabwe. This research was carried out between 20 of October and 15 of December of 2023 through remote weekly group discussions of 1 hour. The first meeting was used mainly to introduce ourselves to each other, to talk about our backgrounds, our experience in harm reduction and also in advocacy. We also revised together the objectives of this working group. We set some common ground rules and decided the dates for the next meetings. Immediately after this first meeting, it was created a shared main document. We all had access to it, and in which we slowly started to structure and organize what eventually became the finalized article that was published.
Teresa?
Yes.
Is everything okay with the presentation? Because we are still watching the methodology slide.
Yeah. Yes.
It's okay?
Yeah, now you can change to the next
Okay.
ones.
Great.
Yeah. So these were some of the research questions that we were asked to answer in order to shape the article. I'm not going to read them, but they're all regarding the needs and challenges of young people who use opioids and young practitioners, and how to overcome these difficulties. At the same time, next slide, we were also asked to collect information about the political situation of our own country, about health services available for young people who use drugs, and about numbers and estimates of young people who use drugs. These research questions and also this data collection were both extremely useful in order to explore each participant's answers and to use them as a starting point to initiate a discussion about the needs and challenges of young people who use opioids, the challenges that us as harm reduction professionals face while implementing harm reduction strategies, and ultimately trying to understand and determine which strategies were most effective to meet these needs and challenges. Next slides. So it was used a qualitative methodology in which we all shared personal experiences and perceptions. And we also resorted to data gathering. In this webinar, we will present the results of this discussion, the key themes that we managed to identify together, and also a set of recommendations that we produced with the goal of addressing effectively the necessities that we found to be more important. Next slide. So, like I previously mentioned, each one of us collected information about the political situation in our own countries regarding drug use, more specifically opioid use, regarding young people who use drugs, and more specifically young people who use opioids, and also the available harm reduction services and overall needs that we managed to detect in our own context. This was very important, not only to identify that there were obvious differences and considerable differences between countries, but also to realize that despite all of these differences and our different backgrounds, there was a shared perspective about the importance of harm reduction as an approach to respond to this problematic. So now I'm going to briefly address some highlights of what each member shared about the political context regarding drug use and availability of harm reduction services in their own countries. So next slide. So in Canada, in recent years, there has been a shift towards harm reduction and decriminalization, but still some challenges persist. For example, there's still a struggle to gain approval for harm reduction initiatives and projects. There's a weak political willingness to upscale safer supply, and drug prohibition still perpetuates. In Indonesia, next slide. Although some regions adopt harm reduction strategies, the country as a whole maintains punitive measures such as mandated rehabilitation. The specialized health services tailored for young people who use drugs are still very rare. In Kenya, so next slide. There's still in place criminalization of drug use, possession, trafficking, possession of drug use-related paraphernalia, and even presence in spaces associated with drug consumption. In the age group of 15 to 24 years old, 1 in 11 people currently use at least one drug. People who use drugs face a lot of stigma and discrimination, and this is even greater when it comes to young people. And there's also lack of youth-tailored harm reduction services and lack of data. In Mexico, there are in place anti-drug policies. There are a lot of challenges in the access to critical and essential treatments such as methadone and naloxone, and there is even currently a national shortage of methadone. There are also inconsistencies in the data collection on drug use patterns, and harm reduction services for young people who use drugs are limited. So now Portugal. So in Portugal, we decriminalized the use and possession of all drugs in 2001. And although this was a very progressive measure, especially for that time. And it obviously had a lot of positive outcomes. We could see that the implementation of harm reduction measures was very slow. For example, drug consumption rooms or drug checking. The drug use and possession until certain amounts is considered an administrative offense, and around half of this happened in the 16 to 24 age group. We have a lack of services dedicated to young people who use drugs. We have an urgent need for more data on this topic, and harm reduction services are still insufficient. In Uganda, there are severe penalties. For example, over 15 years of imprisonment for drug possession and life imprisonment for individuals engaged in drug supply. There is a strong social stigmatization against people who use drugs. The public health response is still very weak. There is a lack of social and political support for harm reduction services, and also an absence of reliable data. In the USA, we can see a prohibitionist approach in which possession, use, and distribution of drugs is prohibited under federal law. Harm reduction measures, even very basic ones such as needle exchange or naloxone, still face a lot of stigma. The use of opioids among young people is increasing. There's a lack of reliable current data, and the health services for young people who use drugs are limited. And last, Zimbabwe. In Zimbabwe, there's criminalization of possession and use of drugs. The opioid use and dependence among young people is increasing. There is also limited recent data on the topic. However, in 2020, it was created the first action plan that aimed to recognize opioid use as a health challenge and not a criminal issue. Still, prevention remains the primary focus, and security and law enforcement are still vital aspects of the plan. By simply analyzing what I presented, so the methodology that we used in this research and how each participant described the political situation of their own countries, it became very clear to me that there are two prevalent ideas that stand out and that are very deeply connected to each other. And they are the need for more data in order to have more understanding on the topic, and also the fact that there is a lack of harm reduction interventions targeting young people who use drugs. I believe these two ideas were stressed by all the participants and became very, very evident. And that's it for me.
Thank you so much, Teresa. Atika, the floor is all yours.
Thank you, Carolina. I'm Atika. I'm one of the co-author. I'm the second author of this report, and I'm presenting the findings that we see from these 8 different countries. So in Indonesia, even though there are buprenorphine for youths who use unregulated opioids, those are still very limited and very limited access. And it's so heavy into basically punishing youths who are using unregulated opioids. That's the same with Kenya. So there are youths who are using opioids for chronic pain, and there are some who are using for non-medical reasons. And it's still very hard to get prescribed options for these folks. There are methadone available in some treatment centers, but in Indonesia, Kenya, Mexico, Uganda, and United States, Zimbabwe, even Canada, those are not really widely available. It's not an instant access that youths can just go to get prescribed options. So basically what we are seeing is that in terms of trend, method of consumption, youths are more likely to smoke rather than inject opioids. And this is consistent. We find this in Indonesia, in the United States, in Canada. And it's harder to get opioids in Indonesia, it's getting harder to get heroin in Canada. There is the unregulated drug that is, basically we are seeing more adulterants, more potent synthetic opioids that are affecting our youths, especially in North America, more pronounced in North America than Indonesia, Kenya, Mexico, Portugal, Uganda, Zimbabwe. And in Portugal, there is the tendency to go into over-medicalization of youths who are using opioids being seen as a disease. And this is also being seen in Canada. We're heading towards the moral panic in which youths who are using opioids seen as disease, like as a chronic disease. And if you're using opioid, you're being seen as a chaotic user. I mean, I really don't like that term. Some use are disordered and some are uncontrolled, but in many cases, opioid use in youths are still controlled, and it's not really reasonable to put that uniform labelization to youths. Also, there is a need for tackling the policy head on. I mean, we have this prohibition policy and thinking that abstinence is best, and yet we see that through our groundwork in these different countries, through our authors, we see that that abstinence-based model doesn't necessarily work, and often it pushes the youths into the side and not really engaging youths in a way that is really meaningful. So consistent engagement with youths who use drugs is still inconsistent. In the United States, there is different political appetite. There are some that it's a very heated debate, and the term harm reduction in North America is being having a bad press. The term harm reduction is gaining bad press. Needle exchange is seen as enabling. Naloxone distribution is being seen as enabling in Canada as well. And we need to note that in North America, this is where the youths are dying, and yet prescribed options remain very low capacity. There is no diamorphine-assisted treatment for youths. There is more and more youths using fentanyl, smoking fentanyl and tolerating fentanyl, and yet it's difficult to basically get that prescribed option in North America. So yes, those are the some of the results. There's also the panic around diversion, the fear that if we prescribe methadone, it will be diverted. We know that prescriptions are diverted if the youths or the clients don't get the prescription that they prefer. So some buprenorphine get diverted in the United States. Some hydromorphone get diverted in Canada, but that's basically because the youths don't under 30 years old don't get the prescribed option that they prefer. So the strict prescribing policy doesn't really help. It doesn't help the toxic drug crisis. It doesn't help save lives, and the moral panic is unfounded. And there are a lot of opinions. There's a lot of heated debate. And there is this sentiment of saving, quote unquote, saving the youths. There's the savior complex that it's going on. So yeah, like even overdose prevention in bathrooms are seeing as a bad thing. The drug consumption sites in Canada are being framed as drug dens. And this is really problematic because it's wrong. So we are not only fighting prohibition, but we're fighting misinformation and the constant unscientific opinions and the reluctance to follow evidence and to follow the recommendations from the harm reduction practitioners. The trend has been shifted, like we said. Youths, when they have the option of injecting or smoking, they prefer the route that is less risky overall in these countries. In Indonesia, because there is no really heroin, there is the alternative would be methamphetamine and benzodiazepine, which when combined gives that euphoric feeling similar to opioid without actually like identical to opioids. And that's the same in Canada, in the United States. It's getting harder to get heroin in Canada. Basically, the most heterogeneous samples are opioids. So fentanyl are the most heterogeneous drug, because once you test it in the Fourier transform spectrometry, you get different things, and you never know what you have in the unregulated drugs, and it's basically very unexpected. It's very dangerous, and this is why we need to expand prescribed options. Now, the term safe supply is still good in some countries, but in North America, it's being seen as a bad thing. It's being seen like, oh, you're replacing addiction with another addiction, which is false. Some people prefer that, and some people prefer diamorphine, some people prefer methadone, but still they have to go into the clinic, and they have to go to the clinic very often. In Canada, the heroin clinic, you have to do your dose supervised. Now, meanwhile, we know that there are some countries in Europe, like Switzerland, where you can do a take-home dosage, and they're more liberal in terms of prescribing, and that's what we need. We need a more liberal prescribing options so that we can prevent diversion. There is also a need of framing things in terms of health promotion and addressing things to prevent public nuance, because the opinion from public is that, oh, I'm seeing youth smoking meth or injecting opioids and smoking fentanyl, and it doesn't look good for us to just talk about injection site. We have to start talking about inhalation booths. We have to start talking about indoor inhalation booths and more options, because harm reduction is a evolving landscape. Now, we're not going to talk about the test strips here now. We know that in Oregon, fentanyl test strips are seen as a paraphernalia. So even trying to make yourself safe and telling our clients to be safe is being seen wrong. Like it's being seen as morally wrong to provide care. And this is why we need to change that. It's not just stigma, it's also the moral ideology behind all of this, and the abstinence focus approach, and thinking that abstinence is superior, thinking that abstinence makes you morally, intellectually, or spiritually superior, which is not how we're supposed to approach it. So even with test strips, like fentanyl test strip, we cannot keep up with the adulterants just through test strips, because people already tolerate fentanyl. Even youths already tolerate fentanyl. So it's not just fentanyl out there. There's dexmedetomidine, there's xylazine, there's benzodiazepine. There's a lot of new adulterants, and we can't solve this crisis through test strips. It's not going to help. So there's also there's a lot of misconception, and this is why it's good to really stick to the evidence and understand that the supply is highly unpredictable, and that's why the youths are dying. It's not because they're prescribed. It's people, when they're prescribed, we never worried about them. When people are on methadone or buprenorphine or get diamorphine, we're not really worried about them. We're worried about those that are taking unregulated drugs. And the more that the policy focuses on trying to eliminate drugs from the street, the more potent it gets. And we see this from the drug checking lab. Now, this is consistent across the United States or Canada with, pouring budgets and millions into trying to get rid of the drugs. Now, we have to change this ideology that we're not going to get rid of the drugs. There's no way we can do that. So test strips, yes, it's helpful for recreational users, youths who are just partying and trying to use opioids for recreational purposes, but it's not going to help youths that are using fentanyl every few hours. Now, we know that there are youths who are really tolerating this. Every hour they take fentanyl. So access to multiple treatment modalities are so important, not just methadone and buprenorphine, not just Suboxone, but also diamorphine, inhalation options, like different formulations, really meet youths where they are. Do they want methadone? Prescribe methadone. Are they ready for abstinence? Give buprenorphine. Do they just seek pharmaceutical euphoria? Diamorphine is good for that. So it's basically just meeting youths where they are, and really stick to the evidence. I mean, people are entitled to opinions, obviously, but when we're talking about policy and the needs of youths, we need to stick into the empirical evidence, to science and randomized clinical trials. So we need more access to opioid medications, options, and formulations. Talk about the evolving nature of these adulterants, and talk to youths about different kinds of need that they need. I mean, we're not only just needing needle exchange anymore. We need bubble pipes. We need hammer pipes. We need a straight pipe. We need to, so it's basically also smoking supplies that need to happen, that we need to distribute. There is funding inconsistencies, and that's because of the politicization that is occurring in all these countries, and moralization, the moral model, right? So closer to the election season is when we're seeing all these very turbulent dynamics in terms of harm reduction, and funding is never easy in 8 of these countries. So yeah, that's what I got to say about our report. Thanks.
Thank you so much, Atika and Teresa. Thank you, Teresa and Atika, of course, for presenting the methodology, the context, and also Atika for telling a little bit about more the situation in North America and in Canada in regards to the issue. Now we are so pleased to have 3 outstanding personalities in the field of harm reduction, safe consumption rooms, and drug checking services, just to say a few of the things that we know them for. Except Oli, I am so lucky to say that I met these people in person, which is sometimes a bit difficult in this scenario of working online, and also myself literally living at the end of the world. So we will start with Peter Krykant. Peter works in the UK-based charity Cranston, leading on events and campaigns to support system change through implementation of policies based in the health and human rights of people who use drugs. He is also a member of the Board of Justice of Released Drugs, and Peter brings his own personal experience of drug use and criminalization to his work and activism. He opened the first drug consumption room in the UK, which operated from a decommissioned ambulance in Glasgow at the height of Scotland's drug death crisis and Glasgow's HIV outbreak. He works closely with a range of leading academics and organizations to help shape and outline key practical measures to tackle, in particular, Scotland's drug death crisis. Peter has published various opinion piece articles, including in The Guardian, The National, and Choking Drugs, and has presented his work to a wide variety of audiences, from university students, online webinars, and international conferences. Peter, the floor is all yours.
Thank you so much for the introduction and the previous speakers as well, and the presentation on the findings and the results. And yeah, it's really interesting to hear you know, the results, and also, you know, the similarities in terms of, you know, what's happened in North America, you know, in terms of the toxic drug supply, and also, you know, the way that that's represented in the media and in the press. And you know, while the last speakers were the two main speakers were speaking, I was just having a little look through Scotland's drug death statistics. We have our drug death statistics released on an annual basis, so we find out normally around August what the drug deaths were for the previous year. So in August this year, we found out the drug deaths for 2023. So in 2023, Scotland had 1,172 drug-related deaths. You know, if we look at that per head of population, those sorts of figures are as high as what we're seeing in North America. And I suppose what we need to understand is that, or what I think the audience and people should understand, is that these figures are happening without a really toxic drug supply. So, you know, we've not seen a big influx of synthetic opioids or xylazine into our current drug supply. So we just in the last 12 to 18 months have started to see more synthetic opioids start to you know, appear throughout the United Kingdom, primarily as xylazine type synthetic opioids, which from all accounts can be more potent than fentanyl. So of course that's a major concern from our perspective of working and living in Scotland, when we already have these figures that are as high as North America without the synthetic opioids. And I was just looking through the figures. So in 2023, when we look at it from a perspective of young people, people under the age of 35, there was 219 deaths in 2023. Now that's an increase from the year before, where there was 198 deaths for people under the age of 35. And I think, you know, this month in particular highlights some of the main challenges that we face, and that we face as, you know, not just a country in Scotland or the United Kingdom, but internationally, the challenges that we face. Now, this is Recovery Month, and for me, some of the hardest challenges come through, you know, the perspective of recovery and abstinence, you know, and we still have this focus when we often work with or try and educate you know, children and younger people about drugs, of, you know, drugs being bad, drugs being something that, you know, you shouldn't do, you know, that you know, if you want to be successful in life, if you want to you know, have a job, do whatever success looks like for you as an individual. If you want to have that success in life, you shouldn't consume substances unless those substances are substances that are deemed to be socially acceptable, and regulated. And in many respects, that's obviously one of the biggest sort of challenges, about the completely unregulated market that we have at the moment, about, educating children and younger people about consuming drugs in a way that they can do so in a way that's as safe as possible, and that's really difficult at the moment, because the education is not about consuming together with other people, about starting low, consuming small amounts, waiting a longer period of time for those for what you've consumed to take effect before redosing. We're not hearing those messages. We're still hearing the messages of drugs bad, people who have had any sort of issues with drug use, who have consumed drugs, where there has been some sort of issue or problem related to the consumption of drugs. Ultimately it should be about abstinence and about recovery, and unfortunately that's the message that I still see. That you often hear recovery month, and people in recovery being loud and proud to break down the stigma, and for me, I see no stigma associated with being abstinent and in recovery from drugs. It's something that's celebrated. I've heard that in the USA and America, that actually, if you say that you're a member of a 12-step fellowship within certain parameters in life, that you can actually be bumped up, because people respect that so much in terms of employment and stuff like that. So and what we see and what the challenges that we face are again very similar. In terms of these people like Adam Zivo, or whatever his name is, the reporter, who have nothing better to do than spread false accusations and rumors, and completely essentially contribute to killing people through the misinformation that they put out on via the National or whatever paper it is, that whatever rag it is that they write for, because it can't be even deemed to be a actual news. We see the same challenges here with publications like the Daily Mail, and we're not talking about rewinding back to the early 1900s, when you had these sorts of reports about people of color being impervious to bullets because of because of cocaine making them impervious to bullets, and these headlines that we've seen in the New York Times in the early 1900s. We're talking about recent articles, and just in the last few years we've had, when we talk about access to safer supply and diamorphine assisted treatment, we've had headlines in national newspapers saying things like heroin handout for junkies. The government's mad plan is to give a heroin handout to junkies, and this is in print and national newspapers. So, again, it's for me, it's a massive challenge, and I hope that we can look to, and we can move towards, and the years ahead is really breaking down the stigma for people who use drugs, and we can start to, in some ways, bridge some gaps between the recovery movement and the harm reduction movement, because I think we need to see people who are in recovery, who are abstinent have those opportunities and have that chance if that's how they choose, and that's the options that they choose, and those options should always be available for people, but they cannot be held up as you know, the ultimate goal for people who use drugs, you know, and yeah, so yeah, so in terms of you know, as a country, you know, what I recently visited La Sala and Krykant and Tijuana and Mexicali, and you know, they then also went on outreach with the sidewalk project in MacArthur Park and with the Hopics in LA, you know, and what we're seeing and what I hope that we can learn from North America is that if we do not take the action now, if we do not start educating people about the toxic drug supply, and if we do not start transitioning and allowing people to move to a safer supply, we are going to miss that opportunity, and we're going to miss that window, because ultimately, you know, what I've heard from colleagues and friends in North America is that what we're seeing is that now people cannot transition onto a safer supply because the drugs are so toxic and so mixed that even if you transfer from a fentanyl safer supply, you know, you've got benzo dope, etc., all mixed in, and people are then
That's
you know,
true, Peter.
yeah,
Like,
yeah,
it's
people,
I agree.
yeah, people are still, you know, not getting that sort of ability to transition because we don't know what's in the supply, so we don't know what a safer supply is for individuals. We still have that opportunity, but if we don't take it very soon, you know, to all accounts, you know, what we're going to see is the drug market just get more and more toxic in the years ahead. So I don't know how long I've been talking for, but it's a real pleasure to be invited along, and yeah, and also learn from the colleagues on the call, and you know, hopefully we can you know, take some of the learning that's been found from this report and implement it into what we're doing here in the UK.
Yeah.
Thank you.
Thank you, Peter. We will have, I hope, a little bit of time to, I mean, for you to exchange with one another, and also to hear or read some of the questions from the participants as well. So we will continue with Oliver Anders. Oliver is a social worker at Abrigado Freiraum, Hamburg. The facility is a counseling site with integrated drug consumption rooms, the third of its kind in Germany. He started his professional path during a 6-month internship at Abrigado in 2018. After finishing his studies, he moved back to Hamburg in 2021 and started working at the drug consumption site. Apart from that, he offers counseling on various topics. Furthermore, he's responsible for the social space around the facility. His job is to manage the expectations of the other stakeholders in the district they are located in. Oli has a video to show us. I will play for you, but Oli, just let me know when I can start doing this.
Yeah, thank you, Carolina, and everyone else on this call. Glad to be here and glad to have the opportunity to speak. One thing before we watch the video, what I can confirm, what the people before me already said, is the unstable heroin purity that we face in Germany. So we don't have drug checking in our institution, but what we hear from all the people that visit us is that the purity is always unstable. So we have other opioids on the rise, which are harder to control if you don't even have the possibility to check them. In our case, this is due to personal, financial, and spacious resources that we can't offer drug checking. And so we always live with a higher risk of consumption when people, especially if people inject those drugs. Yeah, that's what was important to me to say it first. And now I want to invite you all to a little digital walkthrough through our institution by a video. Basically, it's just a video of me walking through the institution, but yeah. Oh yeah, you can, yeah, thank you. Or from the beginning, maybe. Yeah, thank you. And can you stop right there for just a second? Yeah, so what you just saw is basically the area that we call the cafe. This room is always open for all the people who come visit us. We are a low threshold institution, the first drug consumption room in Germany. People that want to come in don't have to tell us their names, so we work totally anonymous, and people just have to be 18 years old, and they have to have the clear motivation to consume illegalized drugs. These are the things that people have to bring. And yeah, if this is the case, they can come in and use our institution to their needs. Thank you. You can go. Yeah, so this is the cafe area. Now we see the kitchen where we have people working, and every day we have a hot meal for 50 cents. And also we have other kinds of food to hand out to all the people that visit us. So then stop right there, please. Yeah, this is the syringe exchange. So people can change like 1 for 1. This is actually, it's a state law in Germany or in Hamburg where I work. We have to change the syringes 1 to 1, so 1 used for 1 new, but it's the most important part. Yeah, the most important part about harm reduction in that for injecting users is to always have fresh and sterile supply. That's why luckily we have this offer. Thank you. Yeah, then stop right there, please. What you saw there in the back, like behind those little walls, those little windows, is the so-called express room. It's the idea that we had to deal with crack consumption, as crack is a very, very fast drug, as you can say, because the consumption itself only takes about 3 to 5 seconds. You can smoke it over a pipe, and people can just go in and out without talking to us. It's made for the people. And what you can see right now is the so-called smoking room. People have to talk to us. You can have you can go to our desk, and then you have 20 minutes of time to sit in there and smoke. Yeah, thank you. Go on, please. This is where we would sit as a social worker or nurses, because we are a mixed team. We have medical and social professionals working at our facility. Yeah. And then stop right there, please. Yeah, so this is the drug consumption room, and people they have to talk to us. They don't have to say the actual name. They can say whatever they want. And yeah, in this room, the syringes are being given out for free, so no one has to bring a used one in there. The only thing you have to tell us is, what are you consuming? And on the right of this, where we just are, that's probably where I would sit. And then I supervise the consumption. So I give the people all the stuff that they need. So for example, the syringes and different kinds of needles. Some people need ascorbine to cook the heroin. Yeah, and then you have unlimited time, apart from the fact if we have a list of people waiting outside, then we have to restrict the time and have to kindly ask people to leave the room. But if someone does not manage to hit the veins and takes more time, we don't kick them out. We can wait, and we have to manage it a bit, but it's always like a process of dealing with every single consumption. Yeah, thank you. Go on, please. Yeah, basically this is just another side. This is where we would sit then as workers, and through these windows you can see the other two rooms again, the smoking room in the front, and in the back, this is the express room. Yeah, so this is all the, thank you for the video. Do I still have time or should I wrap it up?
Yeah, you have 4 more minutes.
Okay. Yeah. I was reading some questions. I'm not sure if I should just answer questions now or just keep on talking.
We can address the questions after Yarelix ends with her presentation, but you still have 4 more minutes if you want to keep on talking.
I'll keep talking then. Yeah, because some things that we also offer weren't on the video. We also have counseling bureaus, like people can come, for example, to me or other people that are as social workers there. We do counseling to basically every single bit of life questions or consumption questions. Most things we do is financial stuff, like the social money you get from the state of Germany or the city that you live in. This is the most part. We would probably, yeah, that's what takes the most time. But people use the counseling for all kinds of questions. So one of the nicer things that I ever did was one guy that visits our institution lost contact to his daughter ages ago, and when he stabilized himself and had a stable way of consumption, he wanted to pick up contact again. And so we were like speaking to the youth department of the city that his daughter lived in, which was very cool. And I still know that he has contact to her. They are writing letters and stuff. So this is also part of the work that we do there. Yeah, we also have a medical room, which our nurses operate. They mostly do wound care. So a lot of the people that come to our institution are homeless, about 30 to 40%. We have about 150 visitors a day. So yeah, 30 to 40% of them are homeless, which is a lot. The biggest problem in the city that I work in is that we don't have enough space for homeless people that are also consumption, that are tolerating consumption. So most people just get kicked out of the institutions when you, for example, smoke or inject. But as we all know, being a substance user does not stop at nighttime. Like, people still have to consume even if they can't go to the facilities anymore. So we close at 7 o'clock, for example. We can't change that. That's also like restricted. Yeah, but there's no sleeping spaces for people that are homeless and also consuming. There are, but it's like 20 or 30. Yeah, what else did I miss? Yeah, I wanted to like wrap it up a little to young people who use opioids. As you heard, we accept people from the age of 18 on. And in Hamburg, I've got a good friend that works for an institution that's called Kids Hamburg. And they also have a cafe, like an open area for people from the age of 10. And yeah, they have to deal with opioid consumption, but they are so restricted. Like, there's a clear separation between youth work and drug work. And all they do to combine these is basically illegal, and they don't get any support. So there's no safer supply. They don't have syringes. They don't have any, not even disinfection to make people like make it safer for them to consume. But they have to listen to the kids coming to their area that tell them, yes, I am a consumer, I am a drug user, but they can't help in that case because there's just a lack of support in exactly this age group. And yeah, just because someone's under the age of 18, we should accept the task to help them and make it possible for them to get safe supply. Even more important is opioid substitution, which is not legal in Germany to do for younger people than 18. You have to buy the substitution on the black market. Like, that's the way the young people have to deal if they are not like already ready for abstinence. Yeah, so this is what we have to deal with, me not so much, because the people that come to our institution are already 18, but that's what she told me, and I wanted to tell you as well, because I think it's pretty hard to hear. When I talked to her, it was, yeah, made me angry and sad. Yeah, I think I'm done. If there's
That was amazing. Thank you so much, Oli. And if you can see in the Q&A button, there is a question that is addressed for you. You can directly type your answer there, or then after Yarelix ends with her presentation, we can answer a couple of questions.
all right.
Okay, so we have now Yarelix, last but not least. She's a first-generation Central American drug policy and harm reduction researcher, advocate, and community outreach worker. Yarelix works at the City Research Scientist with the New York City Department of Health and is currently largely focused on implementation of the first higher technology drug checking research study in New York City, with local syringe service programs and 2 overdose prevention centers. Yarelix is passionate about supporting people throughout the full continuum of drug use, from use for pleasure and healing to overdose prevention. She's the director of the New York City Psychedelic Society, is on the board of directors for the Tennessee Recovery Alliance, the board of directors for the Source Research Foundation, on the advisory board of the psychedelic media group Simsonia, and is an organizer with the Urban Survivors Union and the Alliance for Collaborative Drug Checking. She received her Master's of Science in Public Health in Health Policy at the Johns Hopkins Bloomberg School of Public Health. Wow. Yarelix, it's time for you to share your presentation with us now.
Thank you so much. Is my internet okay? Because it was kind of spotty. So if it's still kind of spotty, I can switch to my phone, but not sure how.
We can hear you. Yeah, we can hear you fine.
Okay, cool. Just checking. Yeah, thank you so much for having me. My name is Yarelix. I use she, her pronouns, and I'm based out of New York City. I'm currently the drug checking manager at the New York City Department of Health. And we have these machines, the drug checking machines, the Fourier transform infrared spectrometers, located at 5 different sites across the city, where people that use any powders or pills can come and get their drugs checked and receive point of care services. So people can come and know what's in their substances. And we provide the services alongside test strips, because test strips are a really important and essential part of every drug checking service. And it's something that can't be replaced because of the detection limit that these machines have. And with that, we try to provide harm reduction counseling to people, regardless of what substance they're using, whether they're using like opiates and trying to maintain their use, or trying to decrease their use and figuring out how to support people through that process, or people who are just using other substances, maybe more recreationally, or on a less frequent basis. 2 of our sites are located within our overdose prevention centers, so within like safe consumption sites. And that's been a really interesting learning period time, because we only have 2 safe consumption sites or drug consumption rooms in the United States that are above ground, and they're both here in New York City. And we started doing drug checking at the same time that we opened those safe consumption sites in the US and in New York City. So in those models, it's nice to be able to have people come in, check their drugs, and then have a space so people can use them and monitor them in those spaces. And also on the inverse, people having really intense reactions or bad reactions to something in the overdose prevention center, and then bringing it to us so that we can try to figure out what's going on. But as everybody knows, like in the US, we're continuing on an overdose crisis. The ways the drug supply continues to change, and it's changing because of prohibition. So for example, like fentanyl has been driving the overdose rates in the country since 2016, 2017, when it started to be like integrated into the supply with heroin and then overcoming and replacing heroin in some places. But unfortunately, as we see things like, for example, at the United Nations, when they start to schedule and make fentanyl precursors illegal and more difficult to obtain, that causes downstream effects that leads to other precursors, such as carfentanil precursors, being easier to acquire. And now we're seeing a decrease in fentanyl and increase in carfentanil, which makes the drug supply more unstable. It makes it harder for harm reduction workers and people that are just like working in overdose prevention to know how to appropriately respond to overdoses, and also just people not knowing what's in their supply. So that's been a challenge for us in drug checking because of the detection limit that the machines have. If there's anything present in tiny amounts, we can't always detect it with these machines. We have to work with our lab partners to detect what might be going on. But in the last, this entire summer, really, we've seen increases in a lot of different synthetic opiates besides just fentanyl. So we've been seeing things like xylazine, which we've been seeing for the last 2-3 years, and an increase in that. But we've also been seeing an increase in a xylazine analog that is many times stronger than xylazine, called medetomidine, that's been showing up in the supply that people aren't quite sure how to respond to. We've been seeing carfentanil. We've been seeing literal industrial chemicals, like this chemical called BTMPS, that is not psychoactive, but just has a lot of potential heart toxicity issues. And it's all because of prohibition. So yeah, I guess in terms of talking about the lay of the land of harm reduction and accessibility for young people who use drugs, it really depends on the state. Every state has a different political orientation and different funding that they allocate to harm reduction or to different services that support people who use drugs. I think I probably live in the city that has allocated the most resources and has the most political will in New York City to offer harm reduction services. So we do have like safe consumption sites. We have the drug checking service. We have naloxone that's readily available in many locations, and they're delivered from even places that are just like community spaces. Whereas there's other places in the country where naloxone is not readily available. So for example, I recently had a family member that's like in early 20s that had an overdose, and they had to call an ambulance, wait for the ambulance to show up, and then give them naloxone to hopefully reverse the overdose in time, because of how there's not naloxone available in the south of the United States. And along that, I think similar to what other folks have mentioned as well, like the ways that harm reduction services or even treatment programs are modeled, they don't allow for people that are under the age of 18 to receive services. So a lot of people, especially young people, are left in a vacuum where they want services or maybe need services, and they're not able to access it because of the ways that laws are structured in the US. So I guess some other things that are coming to mind is, like when I was young, there was a lot of people that would experiment with different drugs, with pills and things like that, and it wouldn't lead to death. But nowadays, given how there's a lot of lack of information, and then there's a lot of adulteration, specifically in the opiate supply, young people who at one point could experiment with pills and be okay are now, experimenting with different substances and dying. And so people are dying at a higher rate than young people are dying at a higher rate than they ever have than in the past, because they may have low tolerances and they're faced with things like fentanyl that they are unaware that is in the supply. And of course, things like lack of education, lack of proper drug education, besides like Just Say No, is not readily available in most like youth curriculum. So people face a lot of stigma, and they don't have a lot of support when they decide to use drugs, and how to properly take care of themselves in these situations. And I think in terms of some of the things that I read on the report that I think really resonated with me, the low threshold services are really, really crucial to be able to be available to like anyone who walks in. So if I know that there's like rules on who should come in and who shouldn't, but if somebody comes in, maybe just like not asking people their age and providing the services anyway, has been something that I think a lot of providers have chosen to do to be able to support people regardless of their age or whatever, you know, background they might come from. Also having more comprehensive drug education that is person-centered and doesn't have stigma as a part of that process, making it centered around the person's goals that they might have for themselves. And of course, then, and this is for young people and across like people everywhere, I think it's really heartbreaking and frankly disgusting to be in a country like the United States that has so many resources and has the availability to pay for things like naloxone and the availability to have expanded treatment options. But because of politics, the country chooses not to do that. And then people are dying unnecessarily. Like every overdose death is a policy failure. And it's something that continues to be fueled by prohibitionist drug policies that could change if there was just not like the political will was there to allow that to happen. But unfortunately, because of some of the scenarios that we're seeing in places like Oregon, where they decriminalized drugs and then it failed or it didn't work. Now we're seeing recriminalization of a lot of different services and also of drugs. And this is spreading in other places like in Idaho and also in California. So as there continues to be more backlash, political backlash to harm reduction, trying to blame harm reduction for the reason why we're continuing to face overdoses, even though it's because of prohibition and because of a lack of safe supply, we're unfortunately going to keep having more deaths. We're going to keep losing more people. So I think if there's more availability or possibility for people who work in harm reduction to think more broadly about what we're doing and why, because I think oftentimes, especially in the US, people can get so pigeonholed in thinking about, oh, we just have to get drug consumption rooms. We just have to get safe supply. And like, yeah, those are part of the larger issues that we need, but we also have to take a look at our economic system and see that capitalism is really fucking up like the ways that we're living. It's making us be more individualistic.
She's gone, right?
Yeah, I think she was having a bit of trouble
Yeah.
with it.
Yeah.
Anyway,
Yeah, maybe she will rejoin. But also, yes.
I was gonna say it was a very dramatic exit.
Yeah.
That's true.
Definitely. She was on fire. She's back.
Sorry
Oh my
about
God,
that. I think my
Yarelix.
internet went out. Is it back?
Yeah. We can see you now.
Okay, cool. I'll wrap it up. So yeah, I think we have to take a look at the larger systems that we're in, and not be so like, we of course have to do everything that we can within the realms that we work in harm reduction and drug policy to think about how we reduce overdose deaths immediately, because that's what's the most pressing issue now. But without having a look at our economic system or the general systems that are interacting with the folks that we work with, like lack of housing, lack of healthcare, like the United States is an extremely capitalistic healthcare system that is constantly failing people and causing people to have to use drugs to cope with day-to-day life. In thinking politically about how we are more intersectional with other movements, whether it's like housing and healthcare, and other human rights, I think that's really essential for us to consider how we continue to support our movement and how we consider where we're going. Because I live in one of the most progressive cities in the country. Our overdose rates continue to skyrocket. We have a lot of supports that other places don't have, and it's because the system continues to fail. Really, anyone who is poor, marginalized, young, doesn't have access to resources. And so, yeah, I just want to end with, I think all the work that we're doing is extremely important and vital, but we also have to think of the broader picture of what we're doing and how we align our politics so that it ends up being more liberatory and accessible for people that don't have access to different resources. Thank you. Sorry that my internet's choppy.
No. You were on fire. That was why. Thank you so much, Yarelix. And we don't have a lot of time, but there's a question that is addressed to all of the panelists, but especially you. The question is from Lydia. So the question is, how does decriminalization equates with your insights on opioid harm reduction? I would like to listen, especially Yarelix and all others.
Yeah, I think so. Some of the ways that law enforcement makes drug use more dangerous is that people who use drugs will actively try to hide their use in like for example, like the people use drugs in public spaces, but they'll hide behind rocks or they'll hide behind shaded areas because they don't want cops to find them and arrest them. And when they do overdose, then they're overdosing in a place that's hard to find people, so they'll die alone because there's nobody there to reverse the overdose. So if we have ways to decriminalize drugs, then it allows for these behaviors to not be so criminalized, and then people will be more likely to like seek support, or maybe be more likely to have access to services that won't land them in jail, as opposed to having supportive services. I think the problem is when there's not also housing, healthcare, communal supports, like different things in place, it's setting up drug decriminalization for failure, because there needs to be these other support services integrated with drug decriminalization for it to be something that allows the person to stabilize. But that's what's coming to mind initially, and I'll pause there to see if other folks have responses.
Yeah, absolutely. Whoever wants to jump in.
Yeah, so in terms of decriminalization, it's not the end goal. It was never the end goal. The end goal is so that we have prescribed options. Now, in British Columbia, there is an ethical report on prescribed and non-prescribed model. So this is expanding on the safer supply. Now there is co-prescribing, so the client and the prescriber talk about the dose, and usually clients do know their dose, but also take-home dosage and even compassion club model. So we really need to go into that kind of model. So, and as long as it's just decriminalization, but no expansion and no options of prescribed opioids, then we're still going to see deaths. I mean, this is the case in Canada and the US, as Yarelix can say. What about decriminalization of prescribed shared consumption? Is it relating to diversion or no? Because in terms of diversion, there are two different kinds of diversion. There is diversion for personal use, and there is a diversion to another person. You sell the prescription to another person versus it's selling to you, like you taking the diverted prescription. And if you're the one taking the diverted prescription, then it's decriminalized. But as soon as you sell it to other people, then it's a crime. So that's just answering the question from one.
Thank you. Teresa, did you want to say something?
I'm not sure I fully understood the question. So I'm not understanding the relation between the insights on opioid harm reduction and decriminalization. I don't know if anyone can explain me better what's the actual question.
So the question is, how does decriminalization equates with your insights on opioid harm reduction? So maybe I am assuming also Atika said this before, and also Yarelix, that because of some things are criminalized, it's harder to implement harm reduction, right?
Oh, okay. So why is decriminalization seen as a good option given our opinions about opiate harm reduction? Is that it?
I don't know if everyone has another thought, but
I think they're just trying to, like, you know, the sort of implementation of harm reduction and the limitations maybe of that in terms of implementing harm reduction under the banner of prohibition. I don't know if that.
So I don't know if I'm answering the question or not, but so being from Portugal and living here my whole life, for me, decriminalization was always a reality. And when I see myself in groups where most people are from countries outside of Europe, mostly, even though in my day-to-day routine, I feel that we have a lot of problems and that it's so hard to get anything done. I feel very privileged because there are a lot of problems that exist in other countries that are not a problem at all for us. But at the same time, if I see myself in a group with other European countries, people from other European countries who didn't decriminalize drugs, I feel that a lot of them have much better strategies, much better harm reduction measures, and that were implemented a lot sooner than us, even though we decriminalized in 2001. We only had drug consumption rooms. I think the first one was in 2019, which is ridiculous because it was stated in the law that it's legal, but it was not implemented. So yeah, I don't know if I'm answering the question or not, but I feel this. I feel that we are very privileged compared to countries that are living a very harsh reality regarding drug use. But at the same time, that it was not the decriminalization in itself that allowed us to get where we are, because other countries are much more advanced than us and they didn't need that to accomplish it.
Thank you, Teresa. We have another question in the Q&A box. It is addressed to Atika. So maybe, Atika, if you can answer the questions while the panelists say their closing remarks, because we are on time, unfortunately. So maybe we can divide actions a little bit like that. So if you can do that, Atika, that would be great. And then Oliver, Peter, Yarelix, and Teresa, if you can say your closing remarks to this webinar, fantastic.
First of all, decriminalization is not legalization. Those are really different things. What we need is the legal framework, and methamphetamine use and benzo. The more inaccessible it is to get heroin or any preferred opioids or morphine, the more likely that a youth would find methamphetamine and benzo together or just methamphetamine alone. And basically, the pattern of use and route is usually intranasal or smoking. Even when given the choice of their syringe and bubble pipe or snort pipe or glasswares, they usually prefer smoking than injecting. It's just because injecting is just intimidating, and finding vein is not always an easy thing to do. How can harms be reduced under policy changes? So there needs to be a scientific-based education about over-ramping methamphetamine and mixing benzo and methamphetamine, looking at mythbusters about, hey, if you're using methamphetamine, just because you're mixing a depressant and stimulants doesn't mean it's going to cancel each other. There needs to be scientific-based education, objective, including the risks, and also normalizing basically like an overdose prevention, but a virtual care. So instead of, in many places, it's not possible to go to safe consumption site or safe inhalation booths, then that's when we need to explore virtual harm reduction. So just like spotting from a distance, what we do, because there is virtually 100% success rate. There's no deaths at all. And if someone quote unquote overdose, then we dispatch an ambulance to their place. So developing safe plans is so good for that. And that's basically how we can reduce harm while the policy looks like this. Yeah, I think that's it.
Thank you, Atika. I don't know who wants to go next.
Okay, I can go. So just to wrap up, Carolina, yeah?
Yeah.
Yeah, okay, so yeah, thanks again for asking me to come along. It's been really interesting, and you know, the decriminalization you know, part of the talk at the end as well. You know, I think you know, for me, decriminalization is just a first step towards where we need to be, you know, in terms of, you know, a regulated market. You know, we still, you know, under decriminalization, it still for me forms some sort of aspect of this that it's wrong to be consuming drugs, you know, and you know, I think most of the problems that we see in society now, you know, around drug use are linked to prohibition. You know, it's the prohibition that's the issue, and it's not the drugs that are the issue. It's the prohibition that's the issue. So, you know, if we look towards the future, I think decriminalization is hopefully just a step towards, you know, a regulated market and allowing people bodily autonomy and the right to consume what they want to consume when they want to consume it. So yeah, and yeah, that's all I would say. And sort of, you know, wrapping up, and I hope that, you know, we can see some major shifts in policy, because things are not looking good here in Scotland in the foreseeable future.
Yeah, absolutely. I think we also need to, there's another comment in the chat about the discussion of decriminalization. We don't have a lot of time, but yeah, it is something that we really need to discuss about. Oli, Teresa, Yarelix, your closing remarks.
Yeah, I can go. For me, oh sorry. Yeah. Thank you again. That's yeah, for everything that you did here and having me. What I need to say every time I'm speaking about like the topics of harm reduction and drug use and the people who do it, for me, and that's the social worker and in me speaking, that the most important thing is to end stigma, make people feeling okay with talking about their habits, make them feel seen and empower them. Don't judge people on how they decided to live their life or how they were forced into living their lives. That's probably the thing that I care about the most. And everything else has been said and wonderfully explained by my fellow participants here. Thank you.
Thank you, Oli.
I can go. Am I supposed to answer the question or just say my final remarks about?
Exactly, final remarks.
Okay, so to me, as a social worker, also, I think it's very important that we focus not only on the health aspects of harm reduction, but also on the social aspects, the need for housing, for food, for everything. I think that there is the focus is too much. There's too much focus on the health part, but health doesn't exist without social determinants, and we need to focus on that, and that's the only way we can change anything.
Thank you, Tere. Yarelix, you're the last one.
Yeah, just want to close by saying thank you so much to everyone that organized this for having me and everyone on this panel. I'm really excited to hear about different people's experiences, and we're all in such different places in terms of you know, like policy and service provision and what's allowed and what's not allowed and what drugs are normal in our supply and not. And so I also hope that we can all learn from each other and see what has worked and what hasn't, because clearly what's happening in the US is not working. It's killing everyone. Not everyone, but a lot of people. And so I really appreciate just having a conversation that has more of a global perspective, because we can think about what it is that we're collectively doing, because we're not operating within a vacuum. Like the policies that obviously the US makes influences the global South, and now we're seeing the ways that the policies are changing in other countries, and other synthetic opiates are starting to proliferate in different supplies. And so I think the more that we are in dialogue with each other and thinking big about what we want and how we can hope to accomplish these big things together, I think will at least give us some hope in the dark times that might be ahead, with prohibition and with the different things that we're dealing with as direct service providers. So yeah, thank you for the space, and I hope that we can continue these conversations further.
Yeah, as I said at the beginning of the webinar, it was an absolute pleasure for me to moderate this panel. And thank you for the participants that stayed for a little bit longer. I apologize again for starting this discussion a little bit late, but we had a problem with our connection. And we will be uploading this session on our YouTube channel soon, so you can rewatch it there. And again, thank you so much to all of the panelists, and I hope I see you soon, all of you. Bye, everyone. Thank you so much.